Hi, everyone. I'm Lindsay Lyon, Assistant Managing Editor of Events at U.S. News and World Report. Welcome to today's webinar, Curbing the Crisis in Rural Healthcare, Solutions to Turn the Tide. Our session today is the latest installment in our Healthcare of Tomorrow series, a forum for hospital executives and healthcare leaders to share insights, best practices, and perspectives on the future of care delivery. I encourage you to visit usnews.com/healthcareoftomorrow for videos and recaps of previous programs and to sign up for updates about future events. Before we get to our panel, just a few quick reminders. We're capturing video of today's session and we'll be making that available to watch on demand for those who register. Look for a follow-up message from our team. We're also live streaming this session on the US News Facebook page. For those of you watching live, if you have questions, we ask that you please type them into the Q&A feature on your screen. Our team will review and give voice to some of those during the course of the hour. Now I'm pleased to introduce our panel. First, we have Charles Alfaro, Executive Advisor to the New Mexico Primary Care Training Consortium at the Center for Health Innovation. Next, Jim Henry, the Firmware Practice Leader for Health and Wellbeing at CallisonRTKL. Alan Morgan, Chief Executive Officer of the National Rural Health Association, and Mary Ellen Pratt, Chief Executive Officer of St. James Parish Hospital in Louisiana. Thank you all for being with us. Now I'll turn it over to Michael Morella, Managing Editor of Events at US News, for the conversation. Michael.
Thank you, Lindsay, and thank you to our panel for being with us today and all of you listening in the audience. As usual, we have a lot of ground to cover, so I want to get right to it. But before we do, I think a lot of our viewers and listeners, for them, the size and the scope of rural communities may be a bit abstract or hard to fathom. Big distances, many facilities spread out, a lack of access to broadband, and so on. So could each of you kind of briefly help us set the scene? Mary Ellen, perhaps I'll call on you first. Could you talk to us a little bit about St. James Parish Hospital in your community in Louisiana?
Sure. Actually, St. James Parish Hospital is a very typical rural hospital. One of the things, though, I did learn pretty quickly on when I started to work in the rural space is that rural is very diverse. And what I experience in the Delta or the South of grave, poverty and things like that are very different than what some of my colleagues might be experiencing in the frontier areas or in the mountainous areas where access becomes more of a, hazardous road conditions or very far distances and those kinds of things. So rural is very different. And because of that, it needs to be, we can't really come up with a single solution to fix all of rural. But St. James Parish Hospital is a critical access hospital. We're in Louisiana. We're about halfway between New Orleans and Baton Rouge. So we're in the southeast kind of tip of Louisiana. We have about 22,000 people, population that we serve. And typical in Louisiana, a lot of we call them parishes rather than counties, are split by the Mississippi River. So half of my population is on one side of the river and the other half is we call it East Bank and West Bank of the Mississippi River. So we've kind of got this divide that we have to deal with. We, like I said, have 25 beds, but our average daily census is running around 9 patients. So, and that's actually a pretty healthy census for a rural hospital. But as I said, typical of a rural hospital, 90% of what we do is outpatient business. It is ambulatory surgery, it's outpatient diagnostics, it's, ER visits, and then all of the clinic volume that we do. We do have 6 clinics as part of our healthcare services and employ some of the physicians that are in those clinics. Because we're between 2 metropolitans, we actually have a pretty large medical staff. I have 130 doctors on my medical staff because of the folks that come in from the outlying areas. So, we're a little bit different in that regard. And then my employees, I employ about 300 employees, and that's pretty significant in a rural community. So we are very much an integral part of the economy here in our parish. So typical of Louisiana, we are agricultural. We We raise sugarcane, and we have a lot of that around, which is one of the reasons why we're rural, because we have low density population. But we also have, because of the river, we've got some petrochemicals. So we have some big plants in our area as well. So.
Thank you. Yeah, that's very helpful. And you said a number of themes I want to come back to. So before we do, Charlie, how about you? Could you talk to us about New Mexico and the area and the people you serve?
Sure. So New Mexico is the 5th largest state geographically, has about over 2 million people. So we're fairly sparsely populated. The majority of people living in the Rio Grande corridor between Albuquerque and Santa Fe, and in the Las Cruces area in the southern part of the state. Area that we developed Hidalgo Medical Services, which is a federally qualified health center, about 26 years ago, was in a county that had no health care at all. 3 hours to the west is Tucson, 3 hours to the east is El Paso, and an hour north to Silver City, which is a town of about 10,000 people that has a hospital where I live today. So we're considered frontier. There's about, in the service area that Hidalgo Medical Services served, and I'm no longer with Hidalgo Medical Services, but the service area is about 5.4 people per square mile. And the service area population for Hidalgo Medical Services was about 40,000 people. So trying to put together a comprehensive healthcare system that's 4 hours from Albuquerque, 3.5 hours from Tucson and El Paso is a complicated proposition. Lack of access to resources as well as shortages of health professionals are pretty severe in that area. As a result of several features of the Affordable Care Act and other things, we were able to put together a teaching health center in the area, and Hidalgo Medical Services now training its own family medicine physicians as part of a statewide network of developing rural based physician training programs, of which I'm executive advisor for the New Mexico Primary Care Training Consortium, and that's what we do. So what we tried to do over the years was establish southwestern New Mexico and Silver City as sort of a hub for rural healthcare thinking in New Mexico, which is very dependent on resources in Santa Fe and Albuquerque, our larger urban areas. But we feel like rural should have a voice, a very strong voice in how policy develops that supports what we want to do. So that's why we created the Center for Health Innovation and the separate Primary Care Training Consortium.
Great, thank you. Well, Alan, in a number of ways, you are that voice on a national scale, you and your team. Could you talk a little bit about, as we broaden and look at sort of the national landscape, the National Rural Health Association, who you serve, your membership and so on?
Absolutely. Well, our membership includes more than 90% of the nation's rural hospitals, rural health clinics, and rural community health centers. We actually represent the breadth of rural health and rural health delivery. We're not a trade organization. We really are interested in the health of rural communities. And we do that through education, networking, and advocacy, of course. Really what we do is we identify best practices, we share those best practices in the hope that we can replicate these across rural communities. And Mary Ellen hit it right on the head when she said, you've seen one rural community, you've seen one rural community, you find that is certainly the case. But there are some very important commonalities. Rural is older, it's sicker, has a lower income. And rural health is the study of workforce shortages. And on top of that, you of course got these financial challenges that you're pressed with. But the good news is a lot of times we just focus in on all those challenges. Because of those challenges, rural has always been a innovation hub when it comes to healthcare delivery. If you want to look at all the innovative practices in rural over the last 20 years, every one of them has its roots in rural health, whether it's community health workers, patient navigators, dental health aides, telehealth. I mean, telehealth, it has its roots in rural America. Well, with the exception of NASA, but what is more rural than space? And so looking at rural communities, you really get a sense of where the country is going to be 10 to 20 years from now. And that's really the importance of it.
Yeah, I love that idea, and thank you for helping. And again, you set the table for a couple of topics I really do want to come back to. You all have. Now, Jim, you are not a provider and not part of the provider community, but you play an essential role in a lot of communities, or urban, rural, and otherwise. Can you talk to us about your background and your role from kind of a health and well-being perspective at Callison?
Yeah, sure. Great. Thank you. And appreciate the comments that were made. We at CallisonRTKL, we're on the design side of trying to help use creative problem solving to try to help solve some of these wicked problems, right? There are these really hard, complicated things that aren't easy to understand. And Alan, I think one of the things that attracts designers to the rural health is using creative problem solving, because that's where innovation happens, right? The things that you're talking about. And I would say that sort of categorizes our firm. I lead the health and well-being practice for CallisonRTKL. We're a multidisciplinary architecture and design practice. We cover a lot of things besides healthcare, I think, which just kind of makes our design practice unique. We do residential, we do workplace, we do places where people do commerce and commercial work. And what I say is that we actually do we do all the design where people do life, right? We design the places where people do life, where people come together. And my role in the firm is to really try to help improve health upstream in all those places, right? So not just the hospitals, but also helping to drive system thinking throughout all of our projects so that we can improve health. And obviously the rural market, the underserved communities, we're not just designing for the elite, we have to design for everybody, health for all, right? And what are the design decisions that we're making that impact, health upstream? So I always say that in our practice, we think about from prevention to precision, and that's a pretty wide spectrum. But we really think that we have an opportunity to impact health, behaviors, choices, but also some of the things that are driving the social determinants that we can actually try to get in and use design as a creative way to solve those problems.
Great, thank you. Yeah, and again, a couple of themes we'll circle back to there, Jim. I do want us to focus on solutions and innovations, but I also just want to help, share a couple of statistics that really struck me when I was preparing for today. Again, just to kind of set the scene. There's a February study from the Chartist Group that noted that more than 130 rural hospitals have closed in the last decade, and more than 400 are vulnerable to closure. I thought it was also striking that, about 1 in 5 people in the US live in rural communities, but less than 10% of physicians in the country practice in those areas. So, right there, those I think are two really broad and telling statistics, but you can get a sense of kind of the ripple effects on individuals and communities. Where do we start in addressing that and making sure that those 400 some hospitals don't close, or as many as possible don't? Mary Ellen, I know you're part of the American Hospital Association's Future of Rural Healthcare Task Force, and that group released a report of recommendations quite recently.
Yeah.
Do you want to start us off, share a couple of kind of key takeaways?
Sure. That task force that I had the privilege of participating on was really to take some of the work that we had done in rural with regard to the vulnerable community, the vulnerable population that we have, and then what are some of the challenges, and then move it to the third step, which is what do we do about it? What are some of the solutions that we could come up with that could help sustain rural hospitals or rural healthcare really in general. And a lot of that sustainability really comes back to financing models. And one of the things that, Alan and I talked about was just how diverse rural is, Well, a lot of times payment methodologies are not very flexible to be adaptable to the needs of our rural communities. And we would want to maybe do things a little bit differently that serve the needs of our population, but we're restricted by the way we get funds and the services that we have to offer and work with in order to be able to maintain that financial sustainability. So some of the solutions that we came up with were really some kind of unique funding sources, and working toward some public-private partnerships that might come to the table with, okay, there's a certain amount of care that's provided and there's a certain amount of healthcare expenditure in a community. If the private payers and the public payers come together and pool that money and then allow the providers to use that in the best needs for the community rather than what they get paid for, then we could maybe start promoting health. We could promote prevention, and in the end, everybody wins. Most importantly, the patient and the healthier population. So that was one solution that we talked about with the public-private funding. We also talked about different ways to look at infrastructure, and I know, you know, a lot of rural hospitals are very old. They were built in the, you know, early 50s based on Hill-Burton funding, and a lot of them haven't been able to, you know, refurbish or replace their facilities. I'm one of the lucky ones. We were actually able to replace our facility about 13 years ago now. And it made a world of a difference in the services that we could provide and the efficiency of the way we could offer services to our community. So that is a really big factor. And so we talked about different ways, again, of pooling funds with public privates and use some of the existing funding that's out there. And, you know, we were a USDA awardee and guarantee for our bonds and things. So some of that to help us replace some of these facilities and to do it in a way that is flexible and appropriate for the needs. One of the other things that I kind of got excited about was we're hoping that we could get CMMI to create a rural design center where, you know, a lot of what CMMI has been doing is innovative work in transformational and how we deliver care, and giving us the time and the resources to test new models. Most of those models have not been appropriate in the rural space, whether they're risk, you know, involving where we don't have enough population to be able to deal with a risk strategy or whatever. And it's frustrating because we know we need to transform. We know we need to be able to deliver care differently, but we don't have that testing platform. So we're proposing that if we came up with something where it would have more of a rural lens on it with regard to what might be some strategies we could do and have the time and the funding to test those out, that could be a real advantage to rural. And then the last thing, you know, we talked about again is just funding sources. There is a lot of grants out there, even through the federal government. There's a good number of grants, but you know, as a CEO of a hospital and in a rural hospital, you have so many things that are on your plate at one time that it's very hard to focus time on grant writing. And yet there's this great opportunity. So we were proposing a way that could bring some professional expertise and skills to the rural space and leverage that in a way that would offer more hospitals the opportunity to go after some of these grants. So that's kind of just the high notes of some of the different funding solutions that we were talking about in that report.
Yeah, that's very helpful. And you know, one thing that I hear there, and then I've heard from a couple of you, you know, this idea, Jim, you mentioned systems thinking and, you know, collaborating, you know, taking kind of a community-based approach in how, you know, the hospital is the anchor institution in a given community. Mm-hmm. Could you talk a little bit about that from your lens, you know, and how you may, you know, if there are lessons you've learned from outside the healthcare realm, transportation or retail or whatever else, how that's kind of informed that idea that health is a lot more than just going to a hospital facility?
Yeah. Yeah, thanks. All those ideas, Mary Ellen, I think were pretty inspiring. I mean, trying to figure out different ways to drive to a better solution, funding being a primary source for how we get stuff done, right? We can have all the great ideas in the world, but if we don't have money to execute it, then how can we move forward? I think from an overall from a health perspective, and I think it kind of goes back to me more like on the well-being side, is that it's not just about physical health, right? And so that trying to create platforms where you have care for the whole person versus just trying to create something for episodic care. And I think that the thing that I see in rural health is that they're trying to solve a much broader context of problems besides just how do I get you in to be seen for this thing that you need help with, right? Which a lot of our cases, and if you do, there's tons of research out there, I don't need to quote it all, but that there's so many avoidable diseases that we have that, that's not the issue, right? In a lot of cases, it could be that they haven't taken care of those issues for a long time, and that we have, an aging population, as Alan pointed out. We've got comorbidities that are happening, and we have to deal with that, and that's why we focus so much on the end. I think system thinking, getting upstream of that, and trying to say, okay, well, we've got to handle the population that we have right now, and put measures in place to help, make suitably care for those patients. And we're going to have a continued aging of America, aging of the world, silvering, all of the terms you want to use. But we have the larger generation right behind that, right? And not in my cohort, but the cohort behind me that are that are making better choices, right? And so what they are concerned about, and what I think we can look at, is total life integration, and really making choices as it relates to pushing things closer together. They're expecting crossover between where, and I think we all want that now. We're seeing crossover. Expectations are omni-channel. We want to see things blended. You ask about where do I see that happening? We see it happening in commerce. We see it happening in retail. We see it happening in all aspects of our world, that everything's pushing closer together and more blended. And so healthcare is, and health prevention and whole health, I would say, is right at the center of that. And so anything we can do as it relates to making places and spaces and experiences more walkable, to encourage more movement, because we know that sedentary lifestyle is going to continue to drive heart disease and other conditions. Better food choices. It costs more money to eat healthy, so how can we create better places where people eat and bring that closer to the communities that need it the most? And then moving, I would say, maybe redistribution, instead of having everything mega located in one location, distributing that into communities where people do life, right? And encouraging that interaction and that collaboration to really be more functionally based versus just episodic.
Charlie, do you want to talk a little bit more about sort of primary care as just really kind of a core foundation? Or that's what it seems like to me. How when we spoke before, you mentioned this idea of training full spectrum doctors and them being so essential in communities. How have you done it? What's your approach out in New Mexico?
Well, I think we spend a lot of time as rural healthcare providers and concerned people mitigating the impact of the basic payment system for healthcare in America. Almost everything we do and try to do through grants and programs and demonstrations is to act against the flow of payment systems in the country, where we call things like paying a lot more for more expensive care relative value, when in fact the value in the payment system should be, and what both Mary Ellen and Jim are talking about, is a better healthcare system that meets a broader range of needs for people that are not just medical, but preventive, social, and economic. But since there's so much weight applied to expensive healthcare, it puts rural areas at a disadvantage because we don't have the population size that can sustain those expensive kinds of healthcare systems. So we're constantly fighting against these incentive priorities and trying to get return on investment from where the greatest payments are, rather than thinking about how we can expand our primary care base and save money by avoiding referrals to larger areas for more expensive care. So I think it's important to realize that because of this payment system, the majority of physicians in America being trained right now are subspecialists. We used to have an 80-20 system where 80% of the physicians being trained in America were primary care providers and 20% were subspecialists when Medicare started. Now it's just the opposite. Now we're at 20% primary care and 80% subspecialists. And the goal in the Institute of Medicine and other countries in the world is 50-50. And we should have 50% of our providers being trained. But there are no incentive for urban-based metropolitan hospitals between DC and Boston to train primary care physicians. So we have to take that upon ourselves. And there are federal rules now that help support that, where 10, 15 years ago when we started thinking about this, there weren't. New changes in the COVID Relief Act in December are making it more possible for rural hospitals to train primary care providers. The Teaching Health Centers program has planning funding, and so we can decentralize the training of primary care providers, which is a fundamentally important concept. Because we're not training very many full spectrum family medicine docs that do deliveries and C-sections anymore, rural hospitals have had to hire more expensive providers to do those kinds of services in order to retain obstetrical delivery services in a community. As a result, I haven't looked in a couple of years, but it was enough a couple of years ago that 57% of rural hospitals discontinued obstetrics in the country. Now, if you have the providers that you can afford to deliver babies and have surgical backup when you need it, then you can't have delivery services. And to me, that's a fundamental economic need in a rural area. If you can't recruit a family in the community because they can't get maternal health care and child health care, then you are not going to be able to develop economically as a rural area. So that fundamental medical thing is important. The other thing is we'd save a lot of money in the expensive part of the healthcare system if we had better social networking systems, social services that support better. It's not just about affordable housing, it's about being able to afford housing. So if your income is better and you have benefits and you can support your family, you're going to have a healthier family. So to me, those are important concepts and demonstrable in rural areas. Like Alan said, rural areas can demonstrate things easier than highly competitive, highly expensive urban environments. We have learned to collaborate. I was speaking in Flagstaff yesterday about rural physician training development, and I talked about it as when you train physicians in a rural area, you have to develop a village. It takes a village to train a physician. You have to have the primary care providers collaborating with the hospitals, collaborating with the behavioral health service providers, working with an integrated social system in your facilities. Those are the important process things that we have to think about working towards, is that integrated local healthcare system that's not just medically oriented, but provides medical assurance to people so that they can live there, but provides a broader range of services to meet their needs. And we would save that money, I believe, in referral to subspecialty hospitals and late end stage care.
Yeah. Alan, are you able to point to any examples of that kind of innovation in action, whether that's reflecting some of the task force's recommendations already, or policy moves or things like that? Do you have any others?
Absolutely. Yes. I'm going to build a little bit off of what Charlie said on the clinical training, and we do this completely backwards in the United States. We take kids who are from upper income families who score high on the MCAT, and they come from places like New York and LA and Dallas. And then we train them in New York, LA, and Dallas. And then we're dumbfounded. They don't want to move to St. James Parish. And we ask Mary Ellen, what's wrong with your community? What don't you have there? Why can't you keep people there? And Charlie's talking about changing how we do the medical education system. We're talking about identifying high school kids in our community, putting them into rural residency training tracks where they're with their peers and having them train in hospitals such as St. James Parish. So they actually see it firsthand, and lo and behold, the data shows that they stick and they love it and they stay and wonderful things. We don't do that. But I think what you're going to see now at the federal level is a very strong push. This pandemic that we've been in has just crushed the workforce nationally. And everyone wants to talk about vaccines, but my membership wants to talk about workforce, and trying to pay 10 to 20,000 or more bonuses to nurses to get them to work in their facilities. Now they're competing against urban areas. So the creative approach from a workforce standpoint is in fact growing our own, identifying our own, and having culturally appropriate people working in our communities that understand our communities. Let me go back to the finance component on it also. And I just want to tee that up. Earlier, you mentioned about the rural hospital closure crisis. And there's this myth that it's happening because people are dying or moving away from rural. The only place that you actually see decreased population nationally when you look at a map is that Western Kansas, North South Dakota, Nebraska. If that was the case, we would see all the rural hospitals closures occurring in that geographic region. Actually, over the last 20 years, rural populations, according to the census, actually increased. Where we're seeing these closures at are in the Southeast and border states. Communities with high African-American populations, high Latino, high Hispanic. It is the problem that we have too many uninsured and underinsured populations in a cluster in these small towns. And financially, you've just got too many patients who can't pay. And so it's important what you're hearing from Charlie and Mary Ellen talk about is changing how we pay to be able to pay for keeping the community healthy and out of the emergency room, as opposed to paying for heads in beds.
I could just add to that a little bit. I think, just a plug for New Mexico, I think we're doing some incredible things around with Medicaid. We just got approval from CMS to expand payments for primary care training as opposed to payments for subspecialty care physician training. We are now, as of last summer, able to pay twice as much in direct graduate medical education payments for physician trainings for primary care and psychiatry as we do for subspecialty care. So we're trying to provide a financial incentives for rural hospitals, FQHCs, and others to train in New Mexico. And for the first time, our federally qualified health centers and rural clinics in New Mexico, rural health clinics in New Mexico, are also eligible for direct graduate medical education payments for physician training through our Medicaid program. And so, that's an incredibly important first step to sort of mitigate the access problem, I think, in rural New Mexico, and our state government and governor and our consortium of all the primary care trainers in the state, I think have made an incredible impact on that. And I think it's a model of potential that, should be taken a look at.
Mary Ellen, what about, thinking about your institution and workforce, or, is that one of the biggest challenges that kind of keeps you up at night, or where are you on that front, or other big challenges?
I've been focusing a lot on workforce, mainly because of the pandemic and what we went through, and the well-being of my staff. I'm very concerned about them, both the medical staff and the nursing staff. It doesn't matter. We all work together through this pandemic. It doesn't matter what you did. We were all exhausted, and I am seeing people retiring. They pushed through the pandemic, but now they're done. They're wanting to retire, and we're having some real problems with recruitment. Partly because of the larger systems are paying so much for recruitment or extra bonuses and things like that, and it's difficult for us to compete on those salaries and wages. But when it comes to physicians and recruiting physicians, I before I came to St. James, I was working at the University of Mississippi Medical Center, and we had the family practice residents come up to our rural hospital. And I remember, talking to the residents all the time, what was their experience like? And they loved coming out to the rural communities. They learned more in my hospital than they did in these other facilities where they had access to all these specialists to say, hey, check out this patient's, cardiac or whatever. In my facility, they had to tap into their own resources, and they loved it. They really felt like they were able to apply their training. Plus the fact our environment is different. I feel like we can compete on our culture. Our culture is rich with compassion and care for our community. We're taking care of our neighbors, our family. These are people we know, and it's a different type of commitment, I think, to the work that we do. And my experience working with the physicians is that they love that environment. And so I really think we've got to get them out into these rural areas. And the fact that they're opening up the door for us to have some training programs in our rural hospitals, I think is going to help flip that switch and get more of them to come out, because they really do. Even my specialists that work in the bigger systems, I'll go check on them when they're here doing a clinic, and they'll tell me all the time, this is my favorite place to work. I love coming out to St. James. So the work environment is really a great experience, and we just have to get them that opportunity to experience it. With regard to my staff, though, we are really working on how do we create well-being in the workspace? What are the pressures in our work environment, and how do we mitigate those? One of the things we did is we wrote a grant, and we got some external funds to allow our staff to go to mental health professionals to de-stress. I had teams of my staff going in group therapy. We actually lost one of our employees to COVID, and it was devastating to my employees. So, recognizing that we need to do this work. I think, one of the things I've been telling, they're like, what do you want to tell other CEOs? My point is, it's in your facility. Look for it. Everybody is dealing, don't pretend like it's not happening to you. It has been an incredibly stressful year, and we need to acknowledge that, and we need to really focus on what does it take. We're doing some different things with technology to try to enhance the experience in the workplace. I'm going to be doing some work with, just pulse monitoring my staff and making sure that we're doing the right things. We're putting in some HR solutions that we think are going to make their work easier and better for them. But I think it's real, and we really, we can't just address it with money. We have to address it with the environment and the workplace. And the one thing I say, I always look for the advantages in rurals, because I know we have a lot of challenges that we have to deal with. But our commitment to our community, the meaning of work that we do, the people that we help, that's the connection that keep people motivated and keep people excited about what they're doing. And we can tap into that, I think, better in a rural space, because these are our family, these are our friends, these are our neighbors, these are people we care about. And so I constantly try to keep that message forward, to keep that energy going in my employees. But it's real, and I have a feeling it's going to get harder rather than easier in the next months to come.
I want to just spend a moment thinking about COVID and some of the lessons that learned. Mary Ellen, you talked just a little bit about your experience there, but Jim, in thinking about vaccination distribution, I think one thing that process has demonstrated is that there is not a one-size-fits-all approach, and that there's a lot of sort of need for small, mobile, easily adaptable spaces and places where these, where vaccines can and care can be delivered. Are there design-oriented solutions that you can point to, or for many of your clients that maybe might be instructive for the next pandemic or for a future crisis?
Yeah, and I'm going to give you maybe a couple of quick answers, and then I will maybe spend a little bit of time talking about some technology. But I think because I want to fit a little bit with what Mary Ellen was saying, but absolutely there's I think having a mobile technology to reach, specific populations, to sort of demystify or whatever it is that we need to do to be able to let people know that it's safe, to bring it to them, to make it convenient, because a lot of rural communities, a lot of underserved communities don't have time off in the middle of the day to go take their kids to the doctor or to go get the vaccine or whatever. So how do we extend the hours of operation? How do we create other places and opportunities for those that are working all the time that don't have, I can't just pick up in the middle of the day and go do it. Oftentimes they're part of our essential, workers and other things like that. So I think that there's a lot of different ways that we can think about mobile, temporary pop-up type spaces that allow that to happen. It's amazing to see the resiliency of our healthcare system during this crisis, and how they responded using whatever means they can to sort of make it happen. I mean, the care teams that we get to work with across the country and in the world at our firm, they're so inspiring because they just get it done. Because at the end of the day, they care so much about the patient. And as what Mary Ellen said, they sacrifice so much personally that it takes a toll, right? But I want to pivot just a little bit and talk about some of the technology, because I think it started out as a telehealth research project that we were doing in our firm. So one of the things that we try to do is actually research some of these tough problems or these things that we think that are solutions. And having using telehealth, and we saw COVID, that was an accelerator, right? There was already telehealth happening. It just wasn't reimbursed properly. It wasn't an equitable payment structure, as Charlie mentioned earlier. There weren't ways of actually leveraging it, although it was already proven to be a very successful tool. And so one of the things that we were looking at was, because of the pandemic, is that actually a really useful tool to hit the population? And one of the things that we identified early is, and there is technology deserts, right? There are these real fundamental things, just like a food desert, there are technology deserts that don't allow, patients to have access to the digital realm. There's a few statistics, look it up here real quick, but 80% of rural health designated as medically underserved, right? So 80% of rural America is designated as medically underserved, and 65%, only 65% of those have access to internet, right? They don't have access to broadband. And so if we try to use that as a tool to sort of help close these gaps, then we're missing a huge gap in the population. So because of that, as a creative problem-solving firm, we try to say, okay, well, what is the solution? So we looked at some different metrics. We fundamentally came to this idea that there's a need of a third space. We say third space in like workplaces, like Starbucks coffee, or at the down in your workplace area where you gather. It's not your office, it's not your home, but it's that third place. And there's a need for something similar to that in health, especially when thinking about this digital divide. That you may not have a safe place at home to do your telehealth. One, it may not be safe. Number two, it may not be accessible via the technology that's in place. So doing a study, and we did a demographic study, and actually a study in a part of Dallas that's a medically underserved. And the conclusion that we came to when we looked at the access to care, we looked at the access to the internet in that particular in that zip code, only 43% of the homes had internet. So there's a huge amount of underserved. Not all of the cell phone coverages would reach those neighborhoods either. They didn't all have 5G. So what is the next best thing, right? And in these communities, it's not something I would have ever thought would have been the solution, but it was convenience stores. Convenience stores, gas stations. It's a fundamental place in some communities, and where they go and commute, they commune together, they get food there. They don't have a grocery store in their neighborhood. They go to the gas station, but they have access to internet. They have, access to food. It's open usually late and, more hours of access. Is that a place where you could put a standalone sort of pop-up clinic or a safe place where someone could enter in and do a two-way visit with the technology? It's unconventional. It's, as someone who wants to design and create great places around the world for health, that wouldn't have been the place I picked. But it is potentially a place where you could deliver care. In some communities, it may be a church. In some communities, it may be a civic center. I think the point is, it's not what the place was. It's the idea of finding ways to meet the needs of your patients in the underserved in unique and challenging ways. So that's something that we're looking at.
Yeah, we're getting some audience questions actually on serving the underserved and on the equity front. Do any of the rest of you have any examples or ideas that you found effective?
Yeah,
Mary Ellen, I'll pick on you.
Yeah, go ahead, because I'm really proud of this. When we started to vaccinate our public, first we were working with our healthcare, folks, but then when it started to move out to the population, it was very apparent in the first couple pods that we did, where we were issuing the vaccine, that it was not representative of our population. It was probably 80% white, 20% African American. And so we realized that, whoa, the way we were doing that was not going to be sufficient. Our population is 50-50. So we obviously were not reaching that population that we wanted to. And they were very vulnerable, because in our data, that our African Americans were more likely to die of COVID. They were more likely to have a severe episode of COVID. So that population was extremely vulnerable, and we really wanted to reach out to it. So we were trying to figure out how to do that. And we have a local state representative that is from our area and is very engaged, very well respected. He and I started talking about it, and we got to our faith-based organizations, our churches, and we started getting it out through that, and having those reverends, pastors, ministers, whatever they would call themselves, preaching literally to their congregations about how important this was, and then reaching out into their communities where they lived. We had to extend our pods from where it was convenient for us to have it to where they needed us to be. And so all of a sudden we started seeing it change. And I just checked our data before, this morning before doing this. And the parish of St. James is 50-50 in our issuance of vaccines completely. So we are definitely proportionate to our population. The state of Louisiana, however, is not quite there. So I feel like the efforts that we made to reach out to that population and to have credible people, and we're still working on it, because the youth now are folks that we're trying to get in to get vaccinated. But again, we're reaching out to folks who are athletes that have made it big and are now back in the community, and using those as folks to get the message out to that population, saying, guys, this is something you really should do. You're protecting your family, you're protecting other people, that kind of a thing. So I think it's really about the messaging and using the right source for that messaging. And then as Jim was saying, we've got to go to where they are. We can't expect them to come to us. So I'm really proud that we've been able to represent our population appropriately with the vaccine distribution.
Great. Charlie, do you want to?
I agree that going to the patient is important, or the people that need the service is important. But I think also important is using telehealth and other technologies to help build the capacity of local providers to provide a broader range of services in better ways. And to the degree that we can not bleed our patients to more urban areas and keep them locally by expanding their capacity through training and everything. One of the programs we do at the Center for Health Innovation is practice detailing. And we go around the state, individuals that we train to work with physicians on the latest protocols for COVID or substance abuse disorder, and work with them so that everybody's getting the latest information. So we're actually going to the providers in their office settings and providing practice detailing around different conditions to support and build the capacity of local providers at their home, where they don't have to do it online, or they don't have to go to a conference, but they can get credit for that training on a one-on-one basis with people who develop, an expertise in that area.
That is such the good point. I want to just build a little bit upon what they said, because now I think it gets very interesting with telehealth as we move forward. I mean, very interesting, because we are the dog that caught the fire cart here and the fire truck. And what I mean by that is we've always advocated for expansion of telehealth. And what we mean is we want the patients in Mary Ellen's and Charlie's community to be able to see the primary care in their home with their physicians. And we want, when they don't have the specialist there, to be able to have the specialist be able to reach them. But I think that the challenge now is, does this open up the opportunity that clinicians from out of the community now will be able to serve and perhaps eat away at just the financial ability for that primary care physician to practice in that community? We got to make sure that we keep the boots on the ground there locally. And I think we can chew gum and walk at the same time, but I think you're going to hear a lot about this give and take now about the appropriate role of telehealth as we move forward. How do we sustain the local healthcare system and not crush that tundra in the process?
Yeah, we've got about 10 minutes left, and so I do want to get to some more audience questions. But Alan, if I could just stay with you real quick, on the policy front, nationally, state level, locally, I think I'd be remiss to not acknowledge that the Affordable Care Act and what the Supreme Court upheld that today. Does that give us clarity moving forward, or are there a couple of ideas on the policy front, infrastructure, broadband, telehealth, that could make a real difference moving forward?
Yeah, let me go back to what we've covered in this call, and it's a good opportunity for us to reiterate that. We have an issue of the patient population in these hundreds of small towns. There are just too many of them that are not able to afford health care. And for those states that have expanded Medicaid, you directly see the correlation between keeping rural hospitals open and the expansion of Medicaid. You see that. It's proven in the data. And so it is a useful tool. So upholding the Affordable Care Act, no matter how you view that politically, it's going to keep rural hospitals open. It's going to keep healthcare access there locally. So that's really important. Now, transitioning on your second part about that is, and you've heard this, hospitals are the largest employer in these rural towns. But you also have very valuable community health centers and rural health clinics that also make up the safety net. It's just important that we view healthcare as infrastructure. And that's the reason why our organization serves on the Rebuild Rural Coalition, an organization of more than 300 rural health organizations. And we're talking Farm Bureau, Farmers Union, National Rural Electric Cooperative, the National Rural Chamber of Commerce, all recognizing that you can't maintain the future of the small town without access to the healthcare. You just can't do that. So going forward, you're definitely going to see any legislation passed on Capitol Hill dealing with infrastructure, having that healthcare component to it. And I'm certainly optimistic we'll see direct provisions included there to address the workforce issues that we've talked about.
We have a question from one of our audience members, and this is for you, Jim. It's about sort of the difference between rural and urban healthcare facilities, or the differences, if there are. Are there a couple of kind of general points you could make, or what are some of the sort of broad design strategies maybe that you could learn from an urban community that could translate to rural facilities?
I would say that it probably mirrors the workforce conversation, because in rural health, you have to have space that can accommodate lots of different things, right? And so I think that the more urban hospitals that we build are designed around specialty care, right? They're designed in the subspecialties. They are designed to handle, a wide variety of emergency type patients and acute care situations for a broad community, right? And then you think about in rural health, you've got the opportunity to make it probably more flexible and adaptable. It needs to change and flex as the needs of the community change. There's some basic fundamentals that are just, these are the basic truths about healthcare architecture that are going to be consistent across both of those. But, as the largest employer in a market, as the place where fundamentally where community gathers, right? It's a community center also. And so creating place where people can gather, that's not necessarily revenue generating, but you're going to have the ability to bring people together and actually teach, educate, some of the other things that maybe are more community based than you do in some hospitals, right? So hospitals in general are leaning more and more towards just a highly effective, building that's churning patients in and out, because it's a not in a bad way. It's just that's the business of healthcare. There's a different philosophy. I think Alan, everyone here on the talked about, it's a understanding those basic human needs. And so there's different kind of space that you need to do that. And I think that if we could take some of those lessons, as you see, I think we're going to see less mega hospitals being built around the country. You're going to see more distribution of health into smaller communities. And you're going to see, so those lessons learned as we start to defrag the healthcare system and put it into our communities, I think you're going to see more of that intervention and those types of design philosophies finding their way into some of those other more distributed healthcare platforms.
Great, thank you. What about another audience question, nursing education? Charlie, you want to talk a little bit about that, how that looks?
Yeah, at least in New Mexico, we have a number of small universities and community colleges that have nursing programs. And I think it's incumbent upon local providers to welcome, health professional students of all kind into their four walls and assist with the training processes. One of the things we did at the Community Health Center in Silver City was we put three loft-style apartments in our Community Health Center on the second floor so that we could take nursing, dental, behavioral health, and other students from other communities and give them housing while they did rotations for a month or two in our community. They got to live downtown, inside the clinic, and walk across the street to restaurants. Alan was actually at our clinic a few years ago looking at that, but we're actually providing living space for learners that are from other communities to come in and stay at our health center while they're there. And I think making those sorts of accommodations for training people, including nurses, nurse practitioners, other nurse specialists, is very important. But I think it's really important that all providers in rural areas understand their role in their own success by becoming trainers and educators and welcoming students and residents and into their community so that they can get that experience. People with any rural healthcare experience during their education are much more likely to work in a rural area than people that have never had any experience. If they end their education in a rural area, like having a residency program in a rural area, they're 3 times more likely than an urban-based program for people to work in a similar rural area, 3 times more likely. So, all of the training in an integrated system is important.
That's so important. And thank you, Charlie. Here's an insider tip on rural health. If you're in a meeting and no one brings up housing or transportation, you're in the wrong meeting. Charlie, you got it in right before the end of this show, so appreciate that. Yeah.
One last question for you all. I want to give you each a chance, thinking back to where we started, looking at solutions and innovations, if you could do one thing, or what's the first thing you would do today or tomorrow, if you could, to, ensure that rural health is accessible, is affordable, and, is able to thrive moving forward. It could be something we've already talked about or something we haven't touched on.
Well, I think we touched on it multiple times, and that is changing how we pay for healthcare. It just is not sustainable in the current system. We need to move away from episodic care and really talking about community health and how do we ensure that whether you're in a rural community health center, a rural health clinic, or a rural hospital, you have sustainable funding to ensure access to care in that community. That access makes all the difference on the downstream cost that we're all paying for healthcare.
It's the fundamental problem.
It is.
For healthcare. It's the basis of our having to do heroic effort to make sure that healthcare is accessible in a rural area. All of us on the screen here have been in that position of having to do things that other people don't have to do in order to sustain healthcare access for people. And I think everybody's to be congratulated on the work that they do.
Agreed. Jim, Mary Ellen, last couple words, anything you add?
I agree with what Alan said, though. It really is fundamentally the payment system that I think is the biggest barrier. It's a barrier for healthcare in general, but it's an extreme barrier for rural. And because what we want to do is take care of our population and whatever they need. And I don't want to be restricted to only what I can do to sustain the funding to be able to stay viable in the future. So I definitely funding is the big thing that needs to change.
Maybe I'll end on an aspirational note and just say that, for me, it's designing places that are going to drive better, healthier decisions and outcomes, right? I think if I could do that, if I could create places that people don't even know they're being healthier by being in it, but it just makes them happier, it makes them more connected to their community, it drives better outcomes, then I think that we can maybe have some interventions that we don't need to treat as many people. So my goal is to try to get to that spot.
Well said, Jim. And again, I want to thank you all for sharing so many great ideas. Thank you all for listening in. Thanks to our panel, Jim Henry, Charlie Alfaro, Alan Morgan, and Mary Ellen Pratt. I look forward to hearing and working with you all in the future. And thanks for being with us today.
It was great. Thank you.
Nice job, Michael.